Thank you, Chairperson, for the kind introduction. At the onset, I thank Dr. Mohan Rao sir and the total team for giving me this opportunity to be here with you at this moment. And I thank Dr. Varalakshmi Garu, who is the energy booster for us, academic booster here. Thank you. So in the next 15 to 20 minutes, just we'll go ahead with because it's a huge topic, neurocritical care, and this 15 to 20 minutes is difficult. Just we'll go through the couple of papers which will help us in the practical decision making while dealing the cases. So we'll go like this. We'll discuss few papers, and we'll conclude by going through a new proposal of differentiating the moderate TBI. Okay. So there are a lot of papers depending upon how to manage the traumatic brain injury, which is a silent epidemic and a deadly killer, which is causing a lot of millions of people in the developed as well as creating a mortality in the developing countries. So this is the Center TBI Studies, which is a collaborative neuro teamwork, which is giving a lot of work on the traumatic brain injuries. So we'll go through the case analysis, case papers, like how we are going to, this David Menon et al. Has studied this management of arterial partial pressures of carbon dioxide in the first week after traumatic brain injury. So, although most of the patients, because all the patients with traumatic brain injury are being treated with mechanical ventilation. So even then, we are not having a proper guideline, proper target of PSCO2s, how much we have to maintain. Because of insufficient evidence, we are not able to guide any recommendations. So that's why. So these people, the Menon et al. Has primarily aimed at checking what are the current practices of PSCO2 in the European centers. And they focused on the lowest PSCO2 value, as well as they are checked in patients with ICU monitoring as well as raised ICP patient. And also these people have evaluated the effect of profound hyperventilation and the long-term outcome. So we all know this hyperventilation is a double-edged sword. It just helps us by creating this vasoconstriction because of perivascular osmosis and reducing the cerebral blood flow, which will help us to reduce the ICP. So this is helpful in case where there is a raised ICP, where we monitor the patient with raised ICP. But most of the ICUs will not have the ICP monitoring. Then in that type of cases, what about this hyperventilation? It carries a potential risk of cerebral ischemia. So we have to know the target of PSCO2. So this study has been studied in the 1100 odd patients with raised as well as non-raised ICPs. This hyperventilation was pretty widely used in the different centers, which was not always rational, and there was what they concluded was there was no clear-cut signals for either beneficial or harmful role. So this slide predicts that, so the lowest PSCO2 values from the various countries, they have been color-coded. The overall mean lowest PSCO2 was around 35 plus or minus 5. So, and they're showing a lot of substantial heterogeneities. So the mean ranged from 32 to 38. The other slide predicts the various centers, the center-specific mean values. The center-specific mean values, which shows that even only in the UK country, this is the yellow is shown by the UK country. In this yellow only, in that country only, a lot of centers are having their own targets of PSCO2. For example, if you consider the average 32 in one center, the average 36 in another center. So purposely, we are not having a particular target of PSCO2. Those slides, this slide shows that there is when the patient is monitored with ICP. So we are having the lowest, the last row which shows the lowest values of around 400 here, 345. The lowest value have been seen when the patient is monitored with ICP. The other cases when we are not monitored in the ICP, we are not having the normal values. So this slotted side predicts the lowest value of PSCO2 when the patient is in monitored ICP, the other patient versus without ICP. So the middle line, the dotted line shows the line of identity. When the data is nearer to this line of identity, it shows that the targeted PSCO2 value is not connected with the ICP monitoring. So coming to the Conclusion of this paper, the manipulation of the PSCO2 is easy and hyperventilation has become a common ICP lowering strategy for an overall half a century. So they observed the huge variability among the centers in the PSCO2 value as well as the usage of hyperventilation. Although the cause inference cannot be drawn from the observational data, it needs further RCTs which can be quite pragmatic. The other paper, this paper, which is a secondary analysis of central TBI study, they have studied this. Hugeman et al. Has studied the impact of high intensive treatment on the patients with traumatic brain injury in the overall European countries. So how we are going to manage the traumatic brain injury? So our main aim is in order to prevent the secondary insult, limiting the impact of secondary insult. And while we are using the method for reducing the ICP, we'll check the adverse effect that drugs and all whatever the methods we use. So our aim here is their aim was to investigate the variation of the use of high intensive treatment as well as this impact on the clinical outcome. So in this study, the total patient was taken into 4,000 patients. When it comes to the ICU, it was around 2,000. After excluding this patient who was not having ICU monitoring, they came to around 700. Out of this, the patient who have received the high intensive treatment was around 41%, around 313 patients were there. So in this 38 patients who have received this high intensive treatment has a favorable outcome when compared to the other patients. This is a slide which shows that the median odds ratio, when the median odds ratio is 1, it shows there is no variation. But here in the slide, they are showing a lot of variations where the patient is having the high intensive treatment. So that is median odd ratio errors on to 2.24. The conclusion is, here in case of this high intensive paper, there is a substantial variation was found in the use of high intensive ICP lowering treatment across the European ICUs. A stepwise escalation strategy from lower to higher intensities level is often lacking. So further research is necessary to study the impact of high intensive therapy. So the other paper is the occurrence and the timing of the withdrawal of life-sustaining measures in the traumatic brain injury. So whenever we are going to have a withdrawal of life-sustaining measures, so we should be very cautious, because if you go early, there is a danger of that we are missing the life. If you are too late, it becomes a burden to the families, hospitals, resources, and on everybody. So in patients with severe brain injury, the withdrawal of life-sustaining measures is common. So for this, in order to prevent early or late, T-Joint Professional Standard Committee as well as Neurocritical Care Society has recommended that in any patient with devastating brain injury, we have to wait up to 72 hours. The aim of the study is to know the occurrence as well as timing of the withdrawal of sustaining measures, and what are the factors which are contribute for the early withdrawal. So what they have concluded is early means less than 72 hours, later means more than 72 hours. There are a lot of factors which contributed for the geographic region as well as the patient and mode of injury. So what they concluded was, they concluded with the impact score. So what they concluded was the occurrence of withdrawal of life-sustaining measures was having a lot of variations. That is, when you consider the Europe, in the eastern region there is only 0% of withdrawal, whereas in case of northern region there is 96% of withdrawal was there. And out of this, the early withdrawals are constituted by 50%. And the strongest predictors were the underactivity of the people is the strongest predictor to take a decision to withdraw the treatment. Regarding coming to the timing of this withdrawal, there was no significant associate with the particular region or center regarding the Europe. This is the impact score, impact unfavorable outcome. Here, the patient who are being in the less than 72 hours is having a high unfavorable outcome as well as high mortality score. So coming to this conclusion of this paper, withdrawal of life-sustaining measures occurs within 72 hours in half of the patient. The occurrence varies between regions. The timing of withdrawal of life-sustaining measures, however, is not influenced by any region. So within 72 hours occurs mostly in patients where he is having a severe devastating injury in the brainstem reflexes. Okay, where the withdrawal of life-sustaining measures is always appropriate or may contribute to a self-fulfilling prophecy, it requires further research. So coming to the next paper, the paper which has shown a lot of improvement in the crash 3 trials, that is the role of tranexamic acid. Here, this gentleman, this Al-Lawaiti et al. Has studied and prepared an excellent systemic review as well as the meta-analysis, but the conclusion was different here. So he has concluded, he has taken into consideration of 9 RCTs, including 1446 patients. What they have shown was there is no statistical significant difference among this patient treated with Trenaxa or placebo group in case of mortality or long-term outcome or hematoma expansion or risk of adverse effects. So he's cautiously concluded that this has no safety issues in patient with traumatic brain injury, and as well as there is what he concluded was, he told that as there was no contraindication also when this patient is associated with other polytrauma patient, we can use the Trenaxa. But per se in patient with isolated traumatic brain injury, however, current evidence may be insufficient to use the Trenaxa. So regarding coming to this new protocol, new categorized protocol by Augustine et al., what they say is because we divide the traumatic brain injury into, we classified as mild, moderate, and severe, depending upon the GCS sum score. Okay. What these people says is when we are classifying this traumatic brain injury, so severe anyhow we are taking care, and mild there is no need of taking care. But the middle person with moderate traumatic brain injury are getting problematic, getting challenged, and facing a lot of struggles. Because I know as a practicing person, practicing intensivist, because if there is any neurosurgeon, kindly just excuse me, because most of my students will be asking, sir, what sir? Our neurosurgeon tells me that no, the GCS is fine, there is no need of intervention presently. Okay, after some times when we just alarm him that GCS is getting poor, then what can be done for this case? So what sir, how should we go with this? So just it's for funny thing. So we have to catch off this moderate TBI. What they say is moderate TBI patients should be considered as potentially severe TBI cases, because in general moderate TBI follows the rule of 30, because 30% of the patient presents with intracranial lesions on the CT scan, as well as 30% will develop neurological deterioration, and it's considered for the 15% mortality. So what this Augustus people tells us is, when you add CT scan radiological finding along with your clinical finding, it will help us to to satisfy the risk in the most of the patient. These are the lot of studies, various studies which have shown that the CT scan has shown a lot of improvement in this type of cases in detecting this abnormalities. So these are the lot of CT scans which predicts how damaging the brain is. Here if you see this bifrontal contusion, these patient usually appears like talk and die patient, because at last moment they will be talking only, suddenly they deteriorate because of the herniation. So we should be cautious while seeing this type of cases. If you follow this this moderately potential, if you consider these type of cases as potentially severe traumatic brain injury, you can save these type of cases. So what they say is traffic line method. We have to go like traffic line method, because the yellow is high alarming. You have to concentrate on this yellow type of patient. Anyhow, the green is for observation, and red is for the dangerous. So when you are considering this CT along with this GCS, so you have to take consideration when the GCS is around 9 to 11, the diffuse lesion will be 1. Diffuse type of lesion will be 1. And we have to consider the patient of GCS from 9 to 13 when the diffuse lesion is around 2 also. So when we are taking care of the no mass lesions or non-evacuated mass lesions, we have to be careful with the patients who is having GCS from 9 to 13. So according to this algorithm, we have to concentrate on these yellows. Then when the patient is having GCS from 9 to 11, or the patient is having GCS even 12 to 13 with the second type of diffuse lesions on the CT, we have to be very cautious, and we have to go with the serial CT scan, serial clinical examination as well as the CT findings. To conclude, the manipulation of PSO2 is easy, and hyperventilation has been common ICU lowering strategies in over half a century. Substantial variation was found in the use of high-intensive ICP lowering treatment across European ICUs. The occurrence of withdrawal of life-sustaining measures varies between the region, and timing, however, is not influenced by any region. So The systemic review regarding the Tranaxa confirmed no safety issues in patients with traumatic brain injury. Consequently, there is no contraindications also. New proposed model of risk stratification in potentially severe traumatic brain injury will reduce the complication and improve the outcome. Thank you.
Thank you, sir, for your excellent presentation. So, in view of constraints of time, we'll take the question in the lunch hour. Next, I'll call upon the Dr. T. Satish, critical care HOD in Apollo Hospital, Secunderabad. The EICU way forward.
Before COVID, it was only EICU we were talking about, or tele-ICUs. And during COVID, apart from ICU, everything else became tele. So what have we decided about tele-ICU or EICU from now on, post-COVID phase? So let's listen to Dr. Satish. Thank you.
Abnormalities. So these are the lot of CT scans which predicts how damaging the brain is. Here, if you see this bifrontal contusion, these patient usually appears like talk and die patient, because at last moment they will be talking only. Suddenly they deteriorate because of the herniation. So we should be cautious while seeing this type of cases. If you follow this this moderately potential, if you consider these type of cases as potentially severe traumatic brain injury, you can save these type of cases. So what they say is traffic line method. We have to go like traffic line method, because the yellow is high alarming. You have to concentrate on this yellow type of patient. Anyhow, the green is for observation, and red is for the dangerous. So when you are considering this CT along with this GCS, so you have to take consideration when the GCS is around 9 to 11, the diffuse lesion will be 1. Diffuse type of lesion will be 1. And we have to consider the patient of GCS from 9 to 13 when the diffuse lesion is around 2 also. So when we are taking care of the no mass lesions or non-evacuated mass lesions, we have to be careful with the patients who is having GCS from 9 to 13. So according to this algorithm, we have to concentrate on these yellows. Then when the patient is having GCS from 9 to 11, or the patient is having GCS even 12 to 13 with the second type of diffuse lesions on the CT, we have to be very cautious, and we have to go with the serial serial clinical examination as well as the CT findings. To conclude, the manipulation of PSO2 is easy, and hyperventilation has been common ICU lowering strategies in over half a century. Substantial variation was found in the use of high-intensive ICP lowering treatment across European ICUs. The occurrence of withdrawal of life-sustaining measures varies between the region, and timing, however, is not influenced by any region. So the systemic review regarding the Tranaxa confirmed no safety issues in patients with traumatic brain injury. Consequently, there is no contraindications also. New proposed model of risk stratification in potentially severe traumatic brain injury will reduce the complication and improve the outcome. Thank you.
Thank you, sir, for your excellent presentation. So in view of constraints of time, we'll take the question in the lunch hour. Next, I'll call upon the Dr. T. Satish, critical care HOD in Apollo Hospital, Secunderabad. The EICU way forward.